thank you all very much for this opportunity to share about my professional passion, which is interventional pulmonology. Well, I'll go ahead and start because this is really about an hour to an hour and 15-minute talk. I spent much of my career in academics, and I failed to ask how long my talk should be. So I am going to try to fly. And I hope you all like picture books because we're going to have lots of pictures. If these lights could go down, it'll probably help if that's a possibility, at least the very front. We're going to talk about what interventional pulmonology is, what conditions we work with, diagnose, and treat, and some new techniques and new technologies in the field. And we're going to do that in kind of a disease-based approach to that. And for housekeeping, I have no conflicts. I have no sponsors, unlike Ricky Bobby. I have no sponsors to tell you about. I'm not trying to sell you anything other than explain what I do, who I am, and hopefully who I can help. So the outline of the talk is who I am, what is an interventional pulmonologist, what is interventional pulmonology, what's used for, what's new. So to start with, obviously, you can see who I am, but as far as what does it take to make an interventional pulmonologist, so you start out with a pulmonologist. So after internal medicine, you do pulmonary training, and then a proceduralist, so someone who has a proclivity and skill set in procedures, and then going on to advanced training. I did my interventional pulmonology fellowship back in 2005, 2006, and there were only 5 or 6 fellowships in the entire US at that time. So fortunately there was one close to where my wife grew up at ECU, and it was a wonderful opportunity. And then the last thing I think to be successful is you have to be a team leader. And this is a picture of my old team when I was in an academic setting, because these patients are very sick. They need help quick, and you just cannot do it alone. So you've got to be a team leader to make it work. So what is interventional pulmonology? So this is a list of the procedures that I can do. There won't be a quiz on this later. But really, what interventional pulmonology is a focus on minimally invasive diagnostic and therapeutic interventions for the chest. That includes lung, the airways, mediastinal diseases, pleural diseases. That's our focus. And it's really born out of pulmonologists being frustrated by lung cancer and having technology developing. So pulmonologists were thinking, how could we help our patients? These are sick people in desperate situations. And so lung cancer is the cornerstone of the interventional pulmonology practice. And it goes all the way from surveillance to treatment of late-stage disease. And we're going to walk through all this in more detail. But there's also benign airway diseases that you can see there. There's benign lung diseases. There's mediastinal diseases that we can help with. And of course, pleural diseases. So we're going to go through that in more detail. So lung cancer. And all these questions are just for Dr. Reichling. You all don't have to answer any of these. He is the only one that needs to respond.
Yeah, well, I
and
filled
we'll
the death
wait.
certificates, and I put lung cancer on every single one. So that percentage is probably a little inaccurate.
So just think in your head, what percent of cancer deaths are due to lung cancer? Well, there's the statistic from the NCI. So only 12.2% of cancers, but almost 21% of cancer deaths. So pulmonologists were very frustrated by this, seeing their patients die at such a high rate, and that's where interventional pulmonology was born. And you can see new cancer cases around 240,000 per year, deaths around 130,000 per year. This is an old graphic, and it's for a subset of population, but you can see lung tracheobronchus, this is mortality. You can add the next 6 or 7 up, and it doesn't even equal that. That's how deadly lung cancer is. And you can see that it's a problem in the SEC. You can see that your lower educated states like Tennessee, I'm sorry, not Florida. But you can see it, North Carolina, we're almost in the red. Basically all your tobacco states have a high incidence. And if we break it down to a state map, Caldwell County is right under the red. We are orange, but we're right under the red as far as our mortality. So it's a big problem for this area, you see there. So what's the 5-year survival rate for lung cancer? 18% is what it used to be. With the newest SEER database, which SEER takes a little while to compile their data, so it's a little bit old, but it's now 25%. So even though that's not great, that's a huge improvement compared to what we used to see. And if you look at stage 4 disease, which approximately half the patients I diagnose every year are going to be stage 3, stage 4, but you're looking at like an 8% 5-year survival rate. So it's very poor. And unfortunately, it's a fairly high incidence, so 1 person out of 14 will be diagnosed with lung cancer that's born today. So screening and surveillance is not a current standard. It's something that we hope to have in the future. There's new technologies. We have this technology, narrowband imaging. If you have somebody that's at very high risk of aerodigestive cancer, this may be employed. As you can see on the far right, really it looks quite bland. But if you look at the vasculature patterns and using this filtering of the light, you can detect cancers earlier. That's really not a current standard, but something that may be used in conjunction with CAT scan screening in the future. So diagnostics, we have lots of things we can do. And we have our old tools that were used basically from the 70s on, including the BAL, transbronchioles, biopsies and yields, etc. And then more advanced technologies. So when I was first in training, when we had a nodule like this, via bronchoscopy, we would quote patients 30% chance we're going to get tissue from this. Because the airways branch just like a tree's branch, it's very hard. You can't navigate out 3 or 4 branches to get to it. So if there happens to be a straight shot, you might get it. And so we had to rely on CT guided biopsies. I don't know if we have any radiologists. Well, we do have a radiologist in the house. You see something that's kind of central like this, no fun. Most people don't want to try to hit something that's 2-3 centimeters from the periphery because you're going to get it in the thorax. Now, if it's something that touches the hilum or mediastinum, then you have a higher chance. You have more like a 70% chance. But those numbers are dramatically different now. All right. So, electromagnetic navigation bronchoscopy came out around 2005 and has continued to develop, but you had technology that allowed you to create a 3D reconstruction of the chest, follow airways out to get close to the lesion, and then aim at it and biopsy it. And so you had this little trigger with you could twist and turn to turn the catheter different ways, and then the technology would tell you you're close to it, but you weren't 100% sure you were close to it. So eventually they incorporated real-time fluoroscopy to give you a better chance of getting into it. And it has made a tremendous difference. It's really cool technology, uses GPS technology that was developed for Israeli missile systems. So the yield jumped up dramatically, and I won't go through a whole lot of the research, but about 80% diagnostic experience. Then robotic bronchoscopy came out, and it came out 5-6 years ago. And the real advantage with it is that you're incorporating all that 3D reconstruction, the modeling of the chest, but then with the robot, you get a fulcrum that's out in the periphery. So if you have to penetrate any lung parenchyma, you can set the robot and it'll have this rigid fix aiming at the lesion, and you can penetrate lung parenchyma. So if you don't have an airway to it, you can still hit it. And that's made a big difference inaccuracy. So here is the brand new NOAA Galaxy system. This is what a robotic system looks like. You mount the disposable bronchoscope onto it, and again, you create this 3D model, you map out to your lesion, and then you drive this thing just like you would play an Xbox. So, to be honest, it doesn't take that much skill, not like it used to, you know, when I was first in training and you're trying to navigate out different airways, but it has increased the yield and decreased your chance of human error. So next is staging. And in staging, there's a couple different technologies that we use to help with staging. So what stages of lung cancer are treated with resection? So right now, 3A and below can be resected. A recent protocol from New England Journal has given us opportunity to help those with 3A. It's been something that's been chased for decades. So staging is tremendously important. And it's something that hasn't always been, we haven't, as a medical community, haven't always been so aggressive enough in pursuing staging, because all lymph nodes that are enlarged are not malignant. All areas or all nodules are not malignant, and sometimes patients will have a mix. And you can see the difference in survival there between M1 disease and M0 disease. Tremendous difference. So staging is very important. It was quite a dilemma for quite some time. I'm going to cut through this. Endobronchial ultrasound has made a huge difference for staging, because most lung cancers are going to spread to the lymph nodes first. And while mediastinoscopy is really good about getting central nodes, your hilar nodes are not accessible. There's a couple different types of ultrasound. There's a radial ultrasound probe and then the curvilinear probe, which is what we usually use. This is the scope. This is the curvilinear ultrasound head. You put a little condom on it so you can have saline here that can form to the tissue, and then you can watch this needle go in. So here's the needle going into the lymph node, that's the blood vessel. So we used to do a blind approach. So I would look at a CAT scan, I would count tracheal rings, I would get an estimate of what, you know, on your 12 o'clock clock, where to go, stick the needle in, and hope that it didn't fill with blood. And if it filled with blood, get a new needle, and go again. And sometimes you have to do that, but this technology has made it so much easier. And we're not only looking at much higher accuracy, but the yield's so much higher, which has become so important because with lung cancer now, the genetics are so important. And you've got to get enough tissue to get the genetics as well. All right. And it's very cost effective. So other technologies that are important with staging are doing thoracenteses, ultrasound exams are important, fluoroscopy or thoracoscopy that we're going to talk about. Sometimes on an ultrasound you can see here nodular changes to the diaphragm that portend a much worse prognosis. And malignant pleural effusions have now become stage 4. It used to be a 3B. It's now 4 because we've solved that most people with effusions are only living about 6 months. So staging is very important. Now for treatment, for endobronchial disease, we have a whole host of different technologies that we can use. The argon plasma coagulator is what is commonly used, and we have a new system as in the OR now, but we're going to have a new cryotherapy system soon, electrocautery that's been around for a while, photodynamic therapy, which we're not going to try to do, but it's an amazing technology, and then balloon dilation, stenting, brachytherapy type of radiation. So I'm going to skip through these different techniques, but this is a before and after picture. You can take someone who's struggling to breathe, open it up, and it may not look pretty the first day, but the amount of air they can move is dramatic. So let's get through the photodynamic therapy, balloon dilation. So airway stenting is something we've already done a fair amount of. It's used for both intrinsic and extrinsic compression of the airway. And oftentimes what happens is these people get obstructed, they develop a bad pneumonia, and that will manifest as symptoms that make them show up. Well, you've got to clear that pneumonia before you give them chemotherapy, or they're just going to get in trouble. And that's where airway stenting can come in, as well as controlling symptoms. And this can be done for benign disease as well. I'll show you some examples of that. Stenting has come a long way. It used to be big, thick silicone stents were used, which dramatically reduced the radius of the airway, and they tend to clog up with mucus. Now the Europeans are making dissolvable stents, and that was the research I was involved with before I left academics, was chasing this hybridized collagen to use as a dissolvable stent. So someday we'll be 3D printing stents specifically for patients' airways. But for now, the technology we have is these are covered stents and then uncovered and semi-covered stents. And there's even Y stents when needed. So here's an example of a lady I had to basically reconstruct her airway. She had this huge tracheal lesion, so you're looking down at the carina, and then her left mainstem was completely plugged. So her right mainstem was open beyond this, but it was very hard for her to move any air to it. So with a couple stents, we got her opened up, and she had advanced stage disease, but lived several more months and was not suffocating. Here's just a before and after picture. You've got some intrinsic disease and probably some extrinsic compressing the airway. These mesh tubes open up and maintain the airway, help with mucus clearance so the patients don't get infected. We also treat benign disease. So this is a fungal infection. We treat a variety of different types, and there's also a procedure for asthma, lung volume reduction, and airway injury. Benign stenosis is something that we see periodically and can be very difficult to manage. We can open people up. We use a variety of different, basically hot and cold technologies to deal with these obstructions. Airway stenting sometimes is used for benign disease. This is a case of malakoplakia in an HIV patient. Another case of tracheal stenosis above a trach tube that was very hard to control. And we also have a procedure for asthma, and this is a pulmonary peroral. This is a slide to remind me to say that all that wheezes is not asthma. So this is a tethered vocal cord. The patient had been diagnosed with refractory asthma. Nothing seemed to work. And obviously it was because they had been intubated and it had inflammation there and ended up with tethered cords. So about 5,000 people die of asthma every year. And there was a procedure called bronchial thermoplasty developed many years ago, and it has somewhat fallen out of favor, but there's a new study that's bringing it back. And I wanted to show this picture of how dynamic the airways can be. So this is the same airway, same vantage point, and you see the difference there. So after 10 years of following patients who received bronchial thermoplasty, they had a dramatic decrease in days work missed, symptoms. Their asthma was well controlled for 10 years. So this is something that we will probably be bringing back. The next treatment for benign airway disease is bronchoscopic lung volume reduction. This is a picture of a one-way valve. This is called the Zephyr valve. There's two different designs. This is the old design. This is research that came out over 20 years ago now. And it took a long time to get valves to the market. The FDA just would not approve it despite multiple rounds of evidence that it helped people with COPD. But a couple different designs, an umbrella design, duckbill inside a stent design. This is what it looks like in the airway. So this is for patients with advanced stage COPD who have heterogeneous disease. And it's usually the upper lobes are severely damaged, the lower lobes are somewhat preserved because as you breathe in, most of your airflow goes to your upper lobes. If they have complete fissures, we can go in with these one-way valves, block airflow to the most damaged parts of the lung, which increases airflow to the more preserved lung, and all of a sudden these patients can breathe so much better. Their oxygen diffusion is so much better. It can be life-changing. With the atelectasis, their big floppy lungs shrink down and their diaphragms start working better. And it really can be life-transforming. Most patients with COPD are not going to qualify for one reason or another, but about a third of advanced stage COPDers, which is still a big number, will qualify and can get this treatment. And there is a survival benefit, about 2 years survival benefit compared to equal patient populations. So airway management. So because the scope lives in the airway, we live in the airway, we get used to dealing with airway issues of all different types. So we can do fiber optic intubation if there's head and neck mass and you need to navigate around. We can do percutaneous tracheostomies, we can manage tracheal injuries and severe tracheal malacia. I do percutaneous tracheostomies. This is a case where the patient had a ruptured trachea. The patient had been intubated on steroids, and you know, sometimes the therapists come in and they, the balloon's kind of soft, keep putting air in, and it can rupture the trachea. So this is a case where we covered up the rupture with a silicone-based stent to allow it to heal. The other big category of diseases that I help deal with are pleural diseases. So one of these pictures is cancer, one of these pictures is TB. And you can think about which one's which. This is the TB. Both of these can cause an effusion with negative cytology. There are some malignancies that will just not shed malignant cells into the fluid. So you do 2 taps, 2 cytologies. If it's negative and you still have an exudate, that's where we have the role of thoracoscopy or pleuroscopy. And so this is a 100-year-old procedure that was done by Dr. Jacobius back in 1923, and it's still relevant today. It's a minimally invasive way to get into the pleura, so you can figure out why does the patient have this recurrent effusion. This is a trapped lung. There's a thick fibrous rind there, and you can see here one of our electric cautery tools going through the scope. We typically will make 1 or 2 ports to get in, and those ports are no more than 1.5 centimeters, 2 centimeters. These are both pictures of benign disease that can cause recurring effusions. There's a variety of different types of pleuritis. Many of the cases I do are for empyema and pneumonic effusions, because if you leave this alone, you're going to end up with a fibrothorax. But if you intervene early, I really believe you can get patients out of the hospital much faster by going in, breaking everything up, and using lytics with a chest tube. There's a lot of advantage to thoracoscopy or pleuroscopy. We do it under conscious sedation, and it's usually fairly mild conscious sedation, and we can get patients out of the hospital much faster. We can do talc if we need to. We go in and it's malignant, we get enough tissue, they can spray talc everywhere, then put in a tunnel chest tube so they can leave the hospital immediately. There's a picture of that. There's a picture of the tunnel chest tube drainage setup. We now have a multitude of indications for tunnel chest tubes, and it's fantastic for maintaining symptoms, even cirrhotics, which used to be thought taboo to drain cirrhotics over and over again. But now there's research. Almost 30% of cirrhotics will get pleurodesis with a tunnel chest tube, which is really impressive numbers, much higher than what I would have thought. Sometimes we have patients with end-stage renal disease on dialysis, and they just cannot manage their fluid. If they've got some heart failure, they just keep reaccumulating pleural effusions, and it really has a huge impact on their life. These tunnel chest tubes can improve their symptoms.